Today our topic for discussion is review the thyroid disease in pregnancy. It's a talk article published in 2018. What are the key content? Trimester specific range should be used to interpret thyroid function during pregnancy. The fetus required maternal thyroxine in first trimester. Optimal management of hypothyroid should be achieved prior to conception. Pregnant women may need to alter their dose of thyroxine in early pregnancy. So thyroxine is very important for brain development, and in that case, if there is hypothyroidism, you will treat as aggressively because up to 12 weeks the fetal thyroid has not been formed. After that, because wholly solely the fetal is properly developed, properly depend on the mother thyroid level. So you have to treat the mother aggressively. In that case, if she is hypothyroid, start her on thyroxine, because up to 12 weeks the fetal brain development is based on the maternal thyroid level. So this article is sufficient for exam. Usually they have given everything, treatment, and explain everything very beautifully. Then treatment for hyperthyroidism can often reduce in third trimester to minimize the risk of fetal hyperthyroidism and then restored postnatally. Human gonadotropin driven hyperthyroidism in hyperemesis gravidarum usually resolve by 20 weeks and does not require antithyroid medication, although thyrotoxicosis must be included. Sometimes the patient with hyperemesis gravidarum present with hyperthyroidism. So basically these both the HCG and the TSH receptors are same. So when the HCG is increases, so along with that superimpose the TSH level is also increases. So you have to exclude hyperthyroidism, you will prescribe thyroid receptor antibody. So this is one of your SBA. It's SBA from mastering and endosizer that in hyperemesis, what you will do for the confirmation of hyperthyroidism, so you will advise her thyroid antibodies. The antithyroid antibodies are negative, so it means that the hyperthyroidism is due to hyperemesis gravidarum. Introduction. Thyroid disease is common in women of childbearing age. It is essential that obstetrician understand the physiological changes brought up by pregnancy and the pathophysiology of thyroid disease. So what is the first of all, we'll understand the basic physiology, then we will understand the related disease, that how it may impact on the pregnancy. So the circulating thyroid hormones are thyroxine and triiodothyronine, of which only the free portion, free T4 and free T3 are active. So in pregnancy, thyroid binding globulin increases. So that's why total T4 and T3 are increasing, but the T3 and T4 are same. So the biologically more important free T3 is formerly main peripherally in the liver, kidney and muscle, where it is converted from free T4 by deiodinase enzyme. This type of physiology is basically from that how it acts. Most tissue include heart, brain and muscle have specific nuclear receptor for free T3, by which metabolic and cellular activities can be influenced. So in normal circumstances, the anterior pituitary produce thyroid hormone as a part of negative feedback loop controlled by free T3 concentration. Dietary iodine is essential for thyroid hormone synthesis. So in fetus, the pituitary thyroid axis is controlled in a similar way, with iodine supplied transplacentally. Prior to 12 weeks gestation, maternal thyroxine not free T4 cross the placenta following binding to receptor in the fetal brain cell. Thyroxine is converted intracellular to free T3, a process through which to be important for normal fetal brain development. So I have told you that up to 12 weeks, prior to 12 weeks, maternal thyroxine is important for brain development. So in that case, you have to treat immediately the patient because it will impact the neurological abnormalities of the babies. From 12 week onward, placental changes prevent significant passage of maternal thyroxine, and fetal thyroid function is controlled independently of the mother, provided that her iodine intake is adequate. When the fetus is athyrotic, however, deiodinase 3 on the fetal side of the placenta is suppressed such that fetal level of T4 can still reach 1/3 that expected in normal pregnancy. So this is the basic mechanism. Well-designed, isolated term placental site show passage to the fetal site only 0.008% of maternal thyroxine in normal circumstances, that is increased 2700-fold by addition of deiodinase inhibitors. So, four important pregnancy-specific changes occur. How sometimes they may ask some question from the physiology that the half-life of thyroxine binding globulin extend from 15 minutes to 3 days, and it is concentration triple by 20 weeks of gestation. As a result of estrogen-driven glycosylation, total thyroid hormone level increase, and the measurement of total T4 and T3 are not reliable in pregnancy, but free T4 and free T3 remain relatively constant and are test of choice in pregnancy. So, in this point, you have to understand that thyroid binding globulin increases. So, in that case, increase total T3 and T4 increasing, but the free is in the normal range. The free T3 flow will be normal until and unless there is any thyroid problem. So investigation of choice in pregnancy is free T3 and free T4, not total, because because thyroid binding globulin increasing in pregnancy, because pregnancy is a hypercog is that type of state that everything some increased concentration, so the plasma concentration, so that's why some values remain the same and some may increases due to pregnancy. So thyroid binding globulin when increasing, so in that case total T3 T4 increasing. So the HCG and the TSH have, the second point is I've already told you that they have similar alpha subunit and receptor. In the first trimester, hormone spillover syndrome can occur in which HCG stimulate the TSH receptor and give a biochemical picture of hyperthyroidism. This is particularly common in multiple pregnancy, trophoblastic disease, and hyperemesis gravidarum, which concentration of both total HCG and thyrotropic subtype can be greater. Thyroid function tests should be interpreted with great caution in these circumstances. So these four points are very important, that how you will, first of all, you will understand the basic physiology, that how these type of mechanism act, and then you will treat the specific disease in pregnancy, because where is the underlying pathology and what to do in the specific if the case came as a multiple pregnancy, trophoblastic, hyperemesis gravidarum, TSH increase, and you will start her on thyroxine. So this is a blunder. So you have to understand the mechanism and physiology, that what you will do in that case. Increased glomerulofiltration rate and greater uptake of iodine into the thyroid gland driven by increased total thyroxine concentration can deplete iodine and cause or worsen iodine deficiency. So when the GFR increases, so there is greater uptake of iodine by the thyroid. So in that case, increased total thyroxine concentration can deplete iodine. Transplacental transfer can also exacerbate this, and when there is severe maternal iodine deficiency, maternal iodine trapping override fetal need, resulting in cretinism. So that's why if the patient is having severe iodine deficiency, that will affect the baby and resulting in overrides the fetal need. So in that lead to the baby may develop cretinisms, and the baby after birth the baby is having these type of symptoms of cretinism. The other thing is 3-deiodinase hormones control the metabolism of T4 to more active form T3 and their breakdown to inactive compound. The concentration of deiodinase 3 increases in placenta with gestation, releasing iodine which is required for transport to the fetus and possibly contributing to the reduced thyroxine transfer. So these are the four mechanisms that how the specific pregnancy specific changes occur, and how the fetus pituitary and thyroid gland control by all these things. So then proceed toward the disease. What is hypothyroidism? It occurs in 1% of the pregnancy. Its management in pregnancy remains surprisingly contentious and complicated. Some state that all women must increase their thyroxine dose at a conception and have their thyroid function tested regularly and throughout the whole pregnancy. Others feel that testing once per trimester is adequate, with dose changes made in response to biochemical state if required, and there is some evidence that excess thyroxine can be harmful. Routine increase in thyroxine must not be advised. So it will depend upon the situation that this type of this talk is very important, that it came as both SBS question, and 2 to 3 SBS come from this topic, and but also it is very important regarding the OSCE station. In OSCE station, the station came as the patient presented with the 8 weeks or 7 weeks gestational area, 7 weeks of amenorrhea with hyperemesis gravidarum. So in that case, you will take the detailed history of hyperemesis gravidarum. What are the causes of that lead to hyperemesis gravidarum? So we will discuss laterly in a bit detail in hyperemesis what are the differential for hyperemesis. So you have to take the detailed history of the hyperemesis gravidarum, then you will proceed toward the examination and then investigation. When you will investigate the patient, you will ask from the examiner that I need certain investigation. So in hyperemesis, you must ask about the thyroid related symptom. So from examiner, you must have to take the investigation of a thyroid related problem. So if the thyroid is deranged, so in that case you will tell the examiner that I need anti-thyroid antibodies. If the anti-thyroid antibodies are positive, so it means that this is a true hyperthyroidism or hypothyroidism that lead to hyperemesis gravidarum. So in that case you will treat the patient accordingly. So this type of station as an OSCE station came in exam. So you have to approach how to approach both for SBS and OSCE station. So this is the approach for that. Then after that, reasons for lack of uniformity in treatment, that there can be confusion between women with untreated hyperthyroidism, low free T4, high TSH, often symptomatic, who required urgent initiation of the treatment in. So there are sometimes different type of presentation with the hypothyroidism. So if someone is a straightforward that untreated hypothyroidism, the patient is having symptoms of lethargy, easy fatigue. The important symptoms for hypothyroidism are that the patient may be lethargy, easy fatigability, weight gain, constipation, hair loss. So these are the symptoms of hypothyroidism. So when you advise the test, it came out to be that low free T4 and high TSH. So this is symptomatic, you will start her immediate on treatment. So other picture is that previously diagnosed hypothyroidism who may be in optimal therapy. The patient present as in pregnancy, when she's having symptoms, when you will do her booking investigation, she came out to be hypothyroid, you will immediately start her on treatment, because up to 12 weeks the fetal thyroid is not working. So maternal thyroxine is very important for the baby, as we have already told detail in physiology. So in that case you will, but if the other picture is that already she is hypothyroid and she is on treatment, what you will do? So at conception, or who may not low free T4 or high TSH. In the later, rapid achievement of euthyroidism is important, particularly in the first trimester. So if sometimes it may be normal, or if it is not normal, low, still the on treatment she is having low free T4 and high TSH. So involve the physician, the concerning physician or endocrinologist, that dose adjustment, because it is very important, and dose adjustment must be in first trimester. The other picture came as subclinical hypothyroidism, normal free T4, raised TSH and asymptomatic, in whom the place of thyroxine therapy is debatable. This is one of the condition that it is subclinical hypothyroidism, that there is raised TSH, the patient have no symptoms, normal free T4, but she's having a raised TSH. So we will usually not treat these type of patient until and unless sometime the most common cause of subclinical hypothyroidism may present patient as recurrent miscarriages. So with subclinical hypothyroidism, usually the patient present with recurrent miscarriages. So in that case, you will treat that patient. But otherwise, in subclinical hypothyroidism, if patient is not symptomatic, we will not treat. So they said that the placement of thyroxine therapy is debatable. So if the patient is having subclinical hypothyroidism, normal free T4 and TSH is high, So in that case, with recurrent miscarriage, you have to treat, because recurrent miscarriage you have all investigation are normal, and her thyroid, there is subclinical hyperthyroidism. So it may be chance that the recurrent miscarriage is due to subclinical hypothyroidism. So you have to treat her. You have to treat her subclinical hypothyroidism, because HCG and all the things, the receptors are same. So obviously they have menstrual problems, and that's why they not conceive. So in that case, you have to treat. Otherwise, in pregnancy, will if the picture is that the patient is normal, you will not treat, and she's pregnant. Hypothyroxanemia, low T4, normal TSH. It is important to decide the target of treatment in pregnancy. For a fetal perceptive, maternal thyroxine concentration do not have a major impact on a fetal thyroid function beyond the first trimester. So in first trimester, it is very important. The thyroxine concentration is very important, but beyond the first trimester, it will have not a major impact on the fetal thyroid. But in first trimester, up to 12 weeks, it have a maternal impact, fetal impact of that disease. The consequences of suboptimal replacement therapy in the first 3 months of pregnancy have been examined by a number of groups. Most of these tests are neurophysiological development of the offspring at age ranges from 3 weeks to 9 years. But inherent problem with these type of tests vary number of factors that influence a child development, that it is difficult to be certain that impact hypothyroidism has on the fetal brain. So first trimester you aggressively treat, because it will have impact on the fetal brain. So in that case, for a maternal perceptive, biochemical euthyroidism remains the goal. As it is outside of the pregnancy, adjustment of thyroxine dose on the basis of clinical sign and symptoms is particularly challenging in pregnancy. Both excess and deficient thyroid hormone can cause problem, and they are difficult to distinguish from those of normal pregnancy. So this result in an increased dependence upon the biochemical result and pregnancy specific ranges. So in pregnancy you have to not it is a problem that you will adjust the dose in pregnancy, because sometimes you will not overdose the patient or underdose the patient, because both have an impact on the mother and the fetus. So in that case, you will in pregnancy the thyroid has other specific ranges. We will discuss on later that what are the pregnancy related specific ranges of thyroid that you have to maintain this level. Outside pregnancy other ranges, but inside pregnancy the ranges are different. So we will discuss later on that what are that. Excess thyroid hormone level, what it causes, that heat intolerance, for example. These are the symptoms of thyroid disease. Those having hyperthyroidism having symptoms of heat intolerance, increased appetite, sweating, palpitation, tachycardia. And those having hyperthyroidism having constipation, tiredness, weight gain, and hair thinning. So these are the symptoms of thyroid disease. So, finally, the therapeutic window for thyroxine is broad, with dose adjustment usually 25 to 50 microgram by approximately 25%. So, if the dose adjustment initially you have to start her on 25 microgram, and then you have to increase according to the adjustment of her level. And by approximately 25%, few individuals are on trigotophore of therapeutic control. Although in pregnancy, increased concentration of thyroid binding proteins occur that result in increased total thyroid hormone pool, and it is unlikely for many women this will not itself necessitate dose adjustment. So in addition, deiodinase 2, the enzyme responsible for peripheral activation of T4 to 3 in the brain, increasing in concentration with advanced gestation when free T4 is low. This may help to explain why thyroxine increase are not routinely required despite the physiological changes well explained above. Then this is reflected in reference range for thyroid function, which are broad. Some state that thyroxine should be increased, such as TSH fall into lower half of the range. Some feel that it would be detrimental. Others feel that individuals have their own narrow normal range, outside which they may develop symptoms to be at increased risk of long-term consequences of hypothyroidism, cardiac failure, or hyperthyroidism atrial fibrillation. So in pregnancy, these questions remain unanswered, as does whether it is circulating free T4 or TSH that is better marker for euthyroidism from maternal baby a mother or baby. So they say that it is not a clear, they did not clear that whether which one is the circulating free T4 or TSH is better marker for thyroidism. So in that case you will advise both TSH or T4 level, but in routine monitoring we will do TSH monitoring. So this situation is further complicated by following issues. Thyroid function can be influenced by hyperemesis gravidarum in the first trimester. Reference ranges for thyroid hormone are different in pregnancy, especially in the third trimester when there is move towards the hypothyroid end of the spectrum. Trimester specific related ranges should be used in management of thyroid related pregnancy. So, factors which with the potential to influence thyroxine dose during pregnancy: reduce absorption in the first trimester related to nausea and vomiting. Malabsorption, so in that case you will adjust the dose, because reduce absorption in the first trimester due to nausea and vomiting. Malabsorption resulting from binding of thyroxine to newly commenced iron and calcium supplement. Suboptimal control prior to conception. Alter compliance with either an improvement resulting in apparent need to reduce the dosage or a deterioration, perhaps from false concern of safety, and normal variation in thyroxine drug. So, overall, for women with under or undertreated hypothyroidism, optimal replacement dose should ideally be reached prior to conception or early in the first trimester. Some women with established hypothyroidism need to increase their dose of thyroxine during pregnancy to maintain the euthyroid according to the first trimester specific changes, but only first trimester control influence being well-being. So whenever the hypothyroidism is when she is already taking thyroid drug and her thyroid is not controlled, so in that case you have to increase the dose, especially in first trimester, because in first trimester there is increased need for the fetus. So in that case, because an already pregnancy related changes occur, that increased dilution occur in the pregnancy, so the drug cannot properly work at that, so you will have to increase the dose. Hypothyroidism, sometimes whenever the patient is hypothyroidism, hypothyroidism is not controlled, so the clinician increase the dose from the normal to increase the dose from 25%. As we have discussed, that if she is taking 25 microgram, then the clinician increase the dose up to 25% increase the dose, because in first time in already pregnancy there is a hemodilution state, so in that case we will increase the dose. Hypothyroidism itself does not influence pregnancy outcome or complication. For women hypothyroidism who intend to pregnant and who are on the correct dose of thyroxine, thyroid testing is needed only pre-pregnancy, early in the first trimester, and again later in the second or third trimester. The majority of the antenatal care can be midwifery led unless risk factor dictate otherwise. So if her controls if her thyroid pre-pregnancy her thyroid level are normal, so in that case you will do her only at one booking, first trimester, first trimester, second trimester, or third trimester. These 3 readings are enough. But if it is not controlled, then you have to regularly do her thyroid level according to adjustment of dose. The other disease, hyperthyroidism. We have discussed the symptoms of hyperthyroidism. The most common autoimmune thyrotoxis or grave disease affect 2 per 1,000 pregnancy. So, as we came from this, that what is the most common cause of hyperthyroidism? So that is Graves' disease. Management is more complex but controversial than that of hypothyroidism. The main tenet is ensure euthyroidism is achieved as early as possible in pregnancy, preferably prior to conception, and this minimizes the likelihood of maternal or fetal complication. Beta blocker, usually propranolol hydrochloride, should be used in pregnancy if required to control tachycardia, tremor, or anxiety. In this context, any concern may be about fetal growth. So, in that case, propranolol is safe. You have to continue in pregnancy to make to keep her tachycardia and anxiety to be treated. Euthyroidism is achieved using anti-thyroid agents, for example, carbimazole or propylthyroxine. These block thyroid hormone synthesis and have an immunosuppressive effect, reduce the titer of TSH receptor stimulating antibodies, and thereby directly influencing the course of disease. So what the action of carbimazole? They block the thyroid hormone synthesis, and that lead to level is control. So in that case, free T4 will be raised and TSH will be low in hypothyroidism. As both of drug can cause the placenta in similar amount, it is important that lowest dose, effective dose, is used to mimic the risk of fetal hypothyroidism. It can be difficult to distinguish clinically between signs and symptoms of hyperthyroidism and pregnancy, so reliance is placed on serial. What are the complications that related if the hypothyroidism is not controlled? Maternal that lead to hypothyroidism, congestive heart failure, preeclampsia, fetal growth restriction, prematurity, and stillbirth. So you have to monitor the patient. If the patient is having hypothyroidism, you at every visit you will check her BP and check her proteinuria and symptoms of any thyroid storm and congestive cardiac failure. You assess her fetal growth for symphysiofertile height at each visit, because these are the factors that complication lead to with hypothyroidism. So in that case, the symptoms of hypothyroidism and pregnancy, so gain reliance is based on serial biochemical measurement, which must be assessed in relation to trimestic specific references. Failure to gain weight despite a good appetite and tachycardia greater than 100 beats per minute that fail to slow with Valsalva minor are good indicators of thyrotoxicosis. So how will you assess for the patient that she's hypothyroidism, she's failed to gain weight and tachycardia greater than 100 beat per minute that failed to slow with the Valsalva minor. These are the and there is rare findings of onchokylosis, elevation of the nail bed. Eye signs and pretibial myxedema do not reflect disease activity. Clinical disease activity follow the titer of TSH receptor antibodies, which rise in first trimester in purpurem and fall in second and third trimester. So thyroid function should be measured monthly when control is good, and more frequently when the diagnosis is new or there is a relapse. So otherwise you will check her free T4 and TSH every monthly. In hypothyroidism, every trimester is insufficient, but in hyper you have to check her monthly, and if it is not controlled then you will according to that situation. Antithyroid medication is titrated. Again, the result, most women therefore reduce their dose, and almost 1/3 of the women can stop treatment during the pregnancy, which help prevent fetal hypothyroidism. So most women will need to restart or increase their dose in the purpurem to avoid relapse. So sometimes these patients are in hyperthyroidism that her disease is controlled. So if you will give her further of her disease is controlled, and you will give her a treatment, so that lead to fetal hypothyroidism. So specifically the relapse is more common in postpartum. So you have to be very vigilant postpartumly, because these patients due to excessive dehydration or any fever, any infection, that more these are more prone toward the thyroid storm. So you have to avoid, keep the patient well hydrated, avoid infection, and that triggers lead to thyroid storm. Propylthyroxine or carbimazole. It is previously felt that as propylthyroxine is more heavily protein bounded than carbimazole, it was less likely to be transferred across the placenta and should be therefore be agent of choice. Using isolated perfuse human placental lobules, however, shows similar placental transfer kinetic for both drugs. So similarly, either suggests that carbimazole causes aplastic cutis congenita of the scalp in the infant, a rare congenital defect causing 0.3% of the general population. So this is association is either spurious and extremely rare and should not be influence the choice of drug in pregnancy. No other teratogenesis has been linked with antithyroid drugs. Indeed, pregnancy in which there is a poor control in the first trimester are more likely to be complicated by fetal anomaly, and in which drug therapy is successful to achieve the control. So both drugs cause agranulocytosis, and pregnant women should be remained to report a sore throat immediately. Their reaction is unpredictable and reason not change during pregnancy. Lactation is the period when there is some difference between the drugs. Studies of radio-labeled drugs such as 0.707 of propylthyroxine and 0.47% have reached the breast milk. Small number of babies, however, where mother have taken antithyroid medication have thyroid function monitored in the first week of life, and adverse effects have not been found. So, honestly, there are concerned that high doses, especially of carbimazole, cause neonatal hypothyroidism. Dose should be therefore split through the day, with feeding to occur with feeding to occur before a dose where possible. So this one you have to, so these are the points that you have to mention as a journal. We have to avoid carbimazole because it will have a congenital effect. So that's why in first trimester we will start her on propylthyrosol. Up to 16 weeks we will give propylthyrosol, and then we have to change to carbimazole in second trimester because carbimazole is a bit teratogenic. So in that case, propylthyrosol, we cannot continue the propylthyrosol because it is having liver toxicity with the propylthyrosol. So in that case, later on, the better option for throughout pregnancy is carbimazole. So this point should be so you have to remember this point, that in first trimester up to 16 will give propylthyrosol, and then second trimester you will change to carbimazole. And with both these drugs, they cause agranulocytosis. So in that case, you have to tell the patient that if the patient develop any sore throat, any fever, so she immediately come to the doctor because it is due to the drug. It is one of the side effect of the drug. And if you are monitoring her TSH every monthly, then CBC should be done every monthly because of to check her WBC count and neutrophils and lymphocytes, because with these drugs they cause agranulocytosis. And the next point is that some amount of breast milk, this drug transfer to the breast milk, so it will have a effect on the baby. So in that, once the baby deliver, you have to monitor because she's taking hyperthyroidism drug, so you will observe the baby for hypothyroidism. And the other thing is that for breastfeeding, this was one of your SBA came as for breastfeeding. How should you tell the patient that how she has taken the drug while breastfeeding. So in that case, you will tell that dose should therefore be split throughout the day, with feeding to occur before a dose where possible. So you have to tell the patient that she should first feed the baby and then take the drug, because it will have a certain concentration in the breast milk. Thyroid surgery or radioactive iodine. Thyroid surgery can be carried out in pregnancy, more usually in the second trimester. Usually you have to remember this, whatever, if there is not any emergency, in that case you will not do surgery in first trimester. Second trimester is safe for surgeries because they increase risk of fetal miscarriage in first trimester. So whenever if the patient is having a very severe emergency, in that case you will do surgery in first trimester. Otherwise the second trimester is best for every surgery. So if the patient has had the drug the patient is not improving with the drug, and her thyroid is not controlled and having symptoms of difficulty in swallowing and aggravation of her thyroid related status, so in that case you will advise surgery in second trimester. And usually you have to remember that radioactive iodine is contraindicated in pregnancy and breastfeeding. So these could be this is one of your SPAs, these 2 points, so you have to remember this. Indication for surgery is compression from a large goiter, suspicion of malignancy, failed antithyroid therapy, and surgery may be more challenging than usual because of the pregnancy associated increase in vascularity of the thyroid, and should be taken by an experienced thyroid surgeon when truly indicated. Radioactive iodine cross the placenta that bind to and destroy the fetal thyroid. It is totally contraindicated pregnancy, and lactation should be stopped preferably 4 weeks prior to treatment if it is given in the puerperium. So these are the points. This is one of your SPAs. So what are the consequences of thyrotoxicosis? Fetal or neonatal problem related to well-controlled grave disease are rare. However, TSH receptor antibodies cross the placenta, and the risk of fetal grave disease after 20 weeks, the gestation rate at which the fetal thyroid can respond to these antibodies, is directly proportional to the titer. Even at the highest titer, the risk is very low. It is very important that women who have grave disease in the past treated by surgery or radioactive iodine, as well as those actively being treated for condition during pregnancy, have antibodies measured. So in grave disease, you have to measure her antibodies level because it will have an impact on the fetal and later on the neonatal problem. So in that case, you have to monitor antibody level. when is the patient is having thyroid along with Graves' disease, because these type of antibodies work on the fetal thyroid. So later on the fetal develop Graves' disease. So you have to monitor her antibodies, because of that it will impact on the baby. Women with positive results should be monitored for sign of fetal thyrotoxicosis, include tachycardia, excessive movement, fetal growth restriction, oligo, and goiter. So these are the important that you have to monitor the baby. Fetal Graves' disease can cause premature delivery in untreated women. In addition, features can be accompanied by any of the following: craniosynostosis and associated intellectual impairment, hydrops fetalis, intrauterine death, polyhydramnion related to esophageal pressure, and obstructed labor from neck extension related to goiter. So these are the very important point, that whenever the patient is hyperthyroidism and having a Graves' disease, you must have to do a baseline free T4, free T3 and TSH level. Along with that, you must have to do her thyroid level, because if her thyroid level are increases, and it will impact on the fetal thyroid and lead to fetal Graves' disease, fetal goiter, and later on the hydrops develop. Interest one of the cause of hydrops is Graves' disease or hyperthyroidism. So management, how you will management is usually based on the delivery. If the gestation age is sufficiently advanced, and if this is not appropriate, high doses of propyltyrosol or carbimazole should be given to mother, and the response titrated against the fetal heart rate. The pregnant woman can take thyroxine if she become clinically hypothyroid, and this will not cross the placenta. Although fetal reference rates for fetal thyroid function are known, fetal blood sampling is not routinely needed, but unless diagnosis in doubt. So and not needed unless if you are in doubt, then you will do fetal blood sampling. Otherwise, it is not needed. You have to treat the mother aggressively with propyltyrosol or carbimazole. And if the patient is hypothyroid with that drugs or due to the condition, so in that case you will advise them thyroxine. At delivery, thyroid function should be measured using cord blood. So once the baby delivers, you have to check her cord blood. Rarely, hypothyroidism is reported secondary to transplacental passage of antithyroid drug, but this is usually self-limiting. Hypothyroidism is only occasionally detected. Although this is more typically present 7 to 10 days postnatally, since the half-life of maternally derived antithyroid drug is shorter than that of TSH receptor antibodies. So in practice, parents should be warned to look for changes in their baby, such as weight loss, poor feeding. Local procedures should be followed by pediatrician, and neonatal treatment when required, rarely loss form. So postnatally, you have to monitor the baby for at least 7 to 10 days, because it takes 7 to 10 days that the maternal antithyroid antibodies, or mother is taking drug. The effect of drugs can be usually take time. So in that case, for up to 7 to 10 days, you will to monitor the baby. So that the hyperemesis gravidarum in the term of vomiting in first half of pregnancy that is sufficiently severe to cause dehydration, required IV fluids, weight loss, abnormalities in the liver function secondary to starvation, or thyroid function test. So this is usually transient. Hyperthyroidism suppressed TSH and high or very free T4 occurring in 60% of the pregnancy with hyperemesis, and is caused by TSH like effect of beta subunit of HCG. It could be an SBA, that how it will affect a TSH like effect of beta subunit of HCG. So in some pregnancy, either the total concentration of HCG is increased, for example in multiple or molar pregnancy, or beta subunit of HCG have a greater ability to bind to TSH receptor. So in that case, the biochemical hypothyroidism must be differentiated from the rare first trimester presentation of Graves' disease with vomiting by taking a detailed history and ensuring a return to biochemical normality. Is hyperemesis resolved by 19 weeks. So this is one of your ASBA, that hyperemesis resolve usually in 19 weeks. It's more than 19 weeks, so it means that there is sometime underlying pathology. TSH have escape full suppression in all women. Typically, in women with hyperemesis, the symptom clearly post-date the pregnancy. The woman is wash out, deflated, and tired. There are no eye sign, goiter, and tachycardia response to IV rehydration. So, if there is a clinical doubt, the absence of thyroid autoantibodies help in supporting so this is one of your SBs. So if you are in doubt, you will do her thyroid autoantibodies. The focus therapy is on correcting the metabolic insult of prolonged vomiting and minimize further vomiting. There is no place for antithyroid medication and there is no intrinsic increase in thyroid activity. The duration of hyperemesis is usually relatively short, and the antithyroid can cross the placenta, which have potentially to make the fetus hypothyroid. So when HCG related thyrotoxicosis is treated, antithyroid medication is either ineffective or very high doses are needed. So these in that case you will not treat the patient. Iodine deficiency. So WHO estimate that worldwide 2 billion are iodine deficient and 20 million have adverse neurological sequelae secondary to intrauterine iodine deprivation. So worldwide neurological cretinism is the leading preventable cause of mental handicap. It affects 2 to 10% of the people in iodine deficiency and cause mild mental handicap and further 10 to 50% such as that IQ distribution curve is move 10 points to the left. The developing cochlea, cerebral neocortex, and the basal ganglia are more sensitive to iodine deficiency, especially in second trimester, result in deaf mutism, intellectual disability, and specific motor disorder. Less severe maternal iodine deprivation sparing speech, motor function, and mental handicap. So iodine is very important. You have to the mother must be not iodine deficient because it will have impact on the baby, because iodine is very important for the baby also, and it lead to cretinisms and lead to because hearing difficulties, because cochlea and cerebral neocortex, we already know that this basically on sodium level. So if the sodium level is decreased, it will impact on the baby. Presume because the mother is able to transfer NFT4 and iodine and the fetus subsequently able to make NFT3 to protect the function. So in the area of endemic iodine deficiency, pregnant women usually have low or very low T4 and normal T3 with raised TSH and a compensatory goiter. So this support the physiological pathway outlined, but the maternal T3 is not enough to protect the fetal brain, which need intracellular T3 derived from circulatory T4. So in this case, there is not enough maternal T4 to be transferred even if deiodinase 2 is suppressed, nor enough iodine to allow fetal production of T4. So changes in renal clearance of iodines in increased thyroxine binding globulin exacerbate the level of iodine deficiency in susceptible population. So it is a compensatory mechanism when there is iodine deficiency. So in that case, the goiter will further there is a activation in the goiters that lead to goiter. So in that case, you have to treat these type of patients. So iodine administration prior to conception or up to second trimester can protect the fetal brain, and when given early enough, reduce miscarriage and later pregnancy loss. So pregnancy programs to deliver an annual bolus of iodine to susceptible women are difficult to sustain, and national program to iodine floor, salt or water contribute to flounder. So in that, in some areas, sometimes the patient came in that areas that they are iodine deficient and having a big goiter, so you have to treat this patient with iodine supplementation, not to give her thyroxine, because as you have seen that her TSH is raised, and with iodine deficiency TSH is raised and T4 is low, and you have to give thyroxine, so it will further suppress the lead to fetal hyperthyroidism. So in that case you will give her iodine administration. So this is one of the important point that we have discussed, but the other talk is that the thyroid dysfunction and reproductive health, it is published in 2015. So there are some they've generally a reproductive health pre-pregnancy, they discuss some points, but they also discuss the pregnancy related thing. So I thought that I will discuss with you that if this specifically given, you have to go through with this. Nothing is very different, because I have already discussed in detail the hypothyroidism and hypothyroidism, but we will discuss only that what are the previously we have discussed the complication of hyperthyroidism. In that in this talk they will give the complication of hypothyroidism in pregnancy. So maternal anemia, PPH, cardiac dysfunction, preeclampsia, placental abruption, fetal distress in labor, prematurity, low birth weight, congenital malformation, perinatal death, stillbirth, neurodevelopmental delay, and congenital hypothyroidism. So these type of the complication are very important, specifically in OSCE station, because when you are starting on management, so you have to evaluate these complication before that, and you have to tell the mother that the hypothyroidism, if it is not treated, then what are the impacts on the mother and neonate. So these are basically for the talks purposes. So, and that the risk factors for the thyroid function, that is, what are the risk factors? So, history of thyroid dysfunction, thyroid surgery, family history of thyroid disease, goiter, positive thyroid autoantibodies, clinical symptoms, type 1 diabetes, because they are autoimmune, so you have to evaluate for diabetes, history of miscarriages, preterm delivery. So, if the patient is having recurrent miscarriages or preterm delivery, you have to evaluate for thyroid. Other autoimmune disorder, history of subfertility, history of therapeutic head or neck irradiation, age more than 30 years, previous treatment with amiodarone, previous treatment with lithium, and previous exposure to iodine radiological contrast agents. So, these are the factors that will lead to thyroid dysfunction. So, you have to be very vigilant. And in that case, there are some trimester specific TSH ranges. You have to memorize these that what are the reference ranges for TSH level. So in first trimester, that is 0.1 to 2.5, you have to maintain her TSH level above 0.1 to 2.5. Second trimester, 0.2 to 3, and third trimester, 0.3 to 3. So for monitoring the TSH is enough. If you